when we go start thinking about patients beyond second line, so third line and beyond, so third or fourth line, we have two options right now, two oral options that are available to us, and they're different options. Regorafenib is a multi-target tyrosine kinase inhibitor, hits VEGF, but hits also FGFR and CSF1R and all these other things. On the other hand, TAS-102 belongs to this family, superfamily of fluoropyrimidines. It's not technically capecitabine or 5-FU because it's equipped to essentially fight some of the elements that drive resistance with 5-FU and capecitabine. So it has activity beyond 5-FU. But it's a cytotoxic agent, so different mechanisms. They've never been compared head-to-head, and so it's very difficult to say if one is preferred over the other because of the lack of a randomized approach to compare the two. Historically, they seem to perform equally well, except they seem to be they seem to have different levels of toxicities. For example, regorafenib has more hand and foot syndrome reaction, which essentially can be detected very early, within 15 days, 15 to 20 days. On the other hand, TAS-102 ends up with more hematologic toxicities. The GI toxicities are somewhat similar between the two, maybe a little bit worse with TAS-102 when they looked at a large Japanese cohort with, it was in one institutional cohort with the two agents, but I think it's about the same. Fatigue is about the same. So most toxicities are about the same. Now, with regorafenib, the standard dose that's approved is 160 milligrams orally on a daily basis, 21 days to 28 days. We recently published results from the REDOS trial, the regorafenib dose optimization study, that actually looked at a different way to give regorafenib, where you start with 80, go to 120, go to 160 as tolerated, so on a weekly basis, and then take a week off versus the 160, 21 out of 28. Interestingly, that study essentially reached its primary endpoint, and our primary endpoint was essentially a composite of both efficacy and toxicity. And in other terms, what this study essentially showed us is that if we look at the percent of patients who are able to start cycle 3, and to start cycle 3, you have to respond to the agent, and you have to be able to tolerate the agent to be able to move to cycle 3. We had at least 17 to 18% more patients get to cycle 3 with a dose escalation strategy versus the standard dose strategy. The toxicities were reduced. The quality of life of the patients was preserved with the regorafenib 80 to 120 to 160. And intriguingly, the survival of patients actually looked better. Although statistically it was not significant, but clinically I think it was meaningful. It was 10 months on the dose optimization schedule, meaning 80 to 120 to 160, versus close to 6 months on the 160, which is what you expect with the 160. So for all these purposes, the REDOS schedule has become our standard practice, with 80 to 120 to 160, and that also because historically it seems to do better than the Rego 160, and historically also seems to do better than TAS-102. In fact, we published recently a network analysis that did suggest that there are these advantages with the 80, 120, 160 versus 160 and the TAS-102. In our practice, every patient that's eligible starts with regorafenib first, and then TAS-102 following regorafenib failure. Now, there are exceptions to this. So a patient who may have had issues with hand and foot syndrome with capecitabine, although again, different reaction, but still obnoxious enough, or patient is borderline performance status, those patients actually will start with TAS-102. For those patients also with some liver dysfunction, a bit reluctant to go with regorafenib, those patients would go on TAS-102. But the majority of the patients will start with regorafenib and then followed by TAS-102.